I'm very excited about this next session. We have Dr. Bob Silver here with us from the University of Utah to discuss stillbirth and what we can be doing better. Thank you all for being here, and thank you, Dr. Silver, for joining us this morning. I will hand it over to you.
Thank you. It's a pleasure to be here. I'm going to see if I can work this to get us where we need to be. So I'm going to talk about stillbirth, and it's really too short to be comprehensive. But I'm going to give an overview and then really focus on things that we can do to try to be better and to try to decrease the rate of stillbirth as best we can. And it's something that I'm really excited to talk about today, because I think there's a time for more optimism in the United States than I've seen in my career. And I think there's been a groundswell and a coalescence of advocates and clinicians and researchers to come together to really try to do better. Because I can't be comprehensive, I'm delighted to talk about anything in the question and answer session. It's also really important to be cognizant of just how emotionally impactful and how devastating each one of these cases are. And sometimes we get lost in the statistics and in the numbers. And I think it's really important to remember that each individual story is just incredibly profound, and we shouldn't lose this when we get into statistics. That being said, there are millions of stillbirths each year, and there's approximately 2 million stillbirths greater than 28 weeks gestation throughout the world. This is almost assuredly an underestimate, because these are under ascertained. And there are different definitions of stillbirth, and that can get confusing, but in the United States, we define this as losses after 20 weeks gestation. And so there's approximately 4 million stillbirths per year, because approximately half of stillbirths occur from 20 to 28 weeks gestations. There's incredible disparities in stillbirths, and 75% of these late stillbirths occur in literally 10 countries, most of them in sub-Saharan Africa and South Asia. Now, many stillbirths are preventable, and one of the best ways to prove that, if you will, is we've had a decrease in stillbirth rates that have been pretty dramatic over the last 25 years. And even in developed countries or high resource settings, we've had a decrease in stillbirth. So that's kind of proof of concept that we can do better. And in fact, the rate's been reduced by about 35% in the last 20 years, from 21 to about 14 per 1,000 births. The total number is reduced by about a third, and the annual rate of reduction has been about 2.3%. The other thing that tells us that we can do better is there's incredible variation by country in terms of the rate of stillbirth reduction. And over this time period, 144 countries had a decrease and 81 had no decrease. Unfortunately, as this slide shows, the United States is really lagging behind other developed countries in terms of the rate of stillbirth reduction. And so our rates of stillbirth are much higher than other countries with similar resources. And our rate of reduction in stillbirth is much lower than other countries with similar resources. And so we can do better. Now, to talk about reducing stillbirth, I think it's helpful to talk about what the causes of stillbirth are. And it's important to distinguish between the causes of stillbirth in high resource settings, where there are certain conditions that tend to cause the majority of stillbirths, and the causes of stillbirth in low resource settings. And for this talk, I'm really going to focus on high resource settings because we're in the United States. But I'm going to spend a little time talking about low resource settings because I think it's critical that we also make efforts to reduce stillbirth in those settings. A lot of the data that I'm going to use for the United States are data derived from something called the Stillbirth Collaborative Research Network, or SCRN. And this is a NIH-sponsored study that we participated in that's occurred over 15 years ago. It was a population-based study. There were 5 geographic catchment areas defined by county lines, occurred in 59 hospitals with over 80,000 deliveries a year, and every woman with a stillbirth and representative population of women with live births were invited to participate. So we took every stillbirth that happened within certain geographic areas, and then there were way too many live births to include all of the live births in this study. So we had a representative population to approximate the general population. So it was a case control study, and there were 663 stillbirths and almost 2,000 live births. Each of the patients had an in-hospital maternal interview. There was medical record abstraction. All of the stillbirths had perinatal autopsy, and all the stillbirths and live births had placental pathology. There were a series of clinically indicated tests, and I'll talk a little bit about that. There were fetal samples and maternal and cord blood and placental samples that were collected for research purposes. We then cataloged or classified the causes of death. And I'm not going to talk about classification of stillbirth or fetal death today, but I'd just like to mention it briefly. You know, it's very easy to simply ascribe a cause of death. Often a cause of death is described as being due to a cord accident or something like that. But there are relatively rigorous criteria that can be used to determine a cause of death. And these are called classification systems, and the SCRN developed a classification system. It's not so important that you become familiar with all the classification systems, but you should know that they're out there and that you should use one of those systems before assigning a cause of death in cases of stillbirth. There are many, many individual causes of death, but they can be grouped into categories. And in thinking about stillbirth prevention, it's helpful to group them into categories because that's how you can figure out where you need to target your prevention efforts. So in the United States, in this study, over a third of the stillbirths were due to placental abnormalities, placental insufficiency. Almost a third were due to obstetric complications, things with similar pathophysiology to preterm labor, preterm premature rupture membranes, and things like that. And then approximately 15% were intrinsic fetal causes like genetic abnormalities or birth defects. And then somewhere 10 to 12 or 13% were due to infections, medical complications like diabetes or lupus or antiphospholipid syndrome. A full 10%, even using rigorous criteria, were due to cord abnormalities, and 10% due to gestational hypertensive disorders. In low resource settings, it's much harder to classify causes of death because there's less evaluation that's done, there's less information that's done. A lot of these patients may not have even had any prenatal care. But it's notable that infection is a much more common cause of stillbirth in low resource settings. And because we know how to mitigate infection, it's a real opportunity for improvement, especially in endemic areas. Malaria and syphilis are very important contributors to stillbirth. And then certainly in low resource settings, especially, improved intrapartum care with a focus on hypoxia and asphyxia can be transformative. It's also important to note that gestational hypertensive disorders and preterm birth are major contributors to stillbirth in low resource settings. Now, we're talking about evaluating stillbirth, and I'll spend a little time on what the optimal evaluation should be. And it's controversial because if we did a complete evaluation with every test that might be useful, it would be cost prohibitive, even in high resource settings. But if you don't do a broad-based systematic evaluation, then you may miss things or attribute stillbirths to conditions that weren't responsible for it. And so we need to balance the cost versus the yield. It does make sense for us to focus on common causes. You're more likely to find something. It makes sense to focus on recurrent conditions, things where you could maybe do something in subsequent pregnancies to reduce the risk. You can also individualize your evaluation of stillbirth by paying attention to clues in the medical or obstetric history, or to clues in the initial part of your evaluation. There's also other complicating features, even in high resource settings of an evaluation, because it can be emotionally challenging. And the most clear or common example is autopsy. Many patients have very levels of comfort with autopsy or genetic testing. So there are two really good studies that highlighted what the most useful tests are for evaluating stillbirth. The first one was done in the Netherlands. It was a multi-center prospective cohort done now 15 to 20 years ago. They had over 1,000 stillbirths, and all of those stillbirths had a comprehensive evaluation. And the classification system that they used was called TULIP, which is cute because they're from the Netherlands. And then their approach, I thought, was very, very useful and a very good way to frame how we evaluate whether a test is helpful or not. They determined if the test in the workup helped to determine the cause of death. So traditionally what we've done is said, you know, if we get a positive result, then that has value. And if we get a negative result, it doesn't. But a positive result that doesn't give you a cause of death may not be that useful. And a negative result in something that you were suspicious of may be very, very useful. So I think that's a good way to frame utility. And so in the TULIP study, the placental examination was abnormal 89% of the time, and it was considered to be valuable 95% of the time. So very, very high value. Autopsy was abnormal 50% of the time, but was considered valuable 73% of the time. Very, very high value. And karyotype was abnormal 12% of the time and was considered valuable 30% of the time. So I think that's a really good way to look at this. Now, because of the TULIP classification system, they probably overvalued placental examination. We did something similar with the SCRN data, and placental pathology, again, was still valuable 65% of the time. So probably the single most important test. Autopsy was also valuable over 40% of the time, so the second most important test. Genetic testing was valuable about 12% of the time, so still very valuable, and antiphospholipid antibody testing about 10% of the time. Other tests were only rarely valuable. So based on these data, we would recommend, whenever possible, doing a fetal autopsy, placental pathology, and then if there are resources available, genetic testing and antiphospholipid antibodies. But most other things can be individualized. Now, autopsy, especially in the United States, is incredibly limited in its use. And there are many concerns. One is cost, and patients are usually not billed directly for this, but the cost is borne by healthcare systems. But a lot of patients, even though they're not billed directly for this, are concerned about it. There's also a lack of trained pathologists. There's a shortage of perinatal pathologists. And then there's discomfort by physicians and patients in discussing this. Sometimes physicians are reluctant to do an evaluation. They may be worried that they're going to be found to be, that their care is going to be implicated as a cause of stillbirth. And then there's a lot of discomfort by patients because they may not understand exactly what an autopsy is. It's not a very appealing thing to have, happen to your child. A lot of people have misconceptions about what's involved. And so it really can be very helpful to work with families to discuss what their reservations are to help resolve any misconceptions that they may have. And often through a little bit of discussion and education, you'll get a much higher uptake on your willingness to do an autopsy. It's also important for people to spend the time and to have those conversations, and physicians often don't want to take the time and are uncomfortable with those conversations. In cases where people don't want to do an autopsy and even after discussions, they still don't want to do it, there are other options that can still provide a lot of information. Partial autopsy, for example, not doing an autopsy on the brain is acceptable to some percentage of families. And then in some cases, x-rays may be valuable or postmortem MRI may be valuable. There's also some new techniques that are being studied with minimally invasive tissue sampling that also may provide information and that may be acceptable for families that don't want to do an autopsy. Another thing that's incredibly important, as we discussed, is placental membranes and umbilical cord evaluation. And people think of the placenta as something where you can get information about placental insufficiency, but you can also get information about infection, genetic abnormalities, anemia, and antiphospholipid syndrome. But just sending a placenta doesn't mean that you're going to get a really valuable set of data back. It really helps to have trained pathologists, and they really need to use a scientific and systematic evaluation. If they're perinatal pathologists, then that will work great. If they're not perinatal pathologists, if they follow the protocols and report using the criteria that have been set forth by perinatal pathologists, and they're termed the Amsterdam criteria because they were put together at a meeting in Amsterdam, then you can get really valuable information. But if you have a general pathologist who's not an expert in placental pathology, then this won't be as informative. I'd like to spend a little bit of time talking about genetic abnormalities because I think that there's been an explosion in molecular genetic technology, and it's really providing additional information that we didn't have before. And the test now that's widely available is microarray, and this in some ways has been termed the future of genetic testing for pregnancy loss. The main advantage is it does not require live cells. And so when you have a stillbirth, you have tissue that's not viable. And so to try to culture those cells to obtain a karyotype or chromosome analysis often fails. And so by being able to simply extract DNA, even in cells that are not alive, can really help give us additional information. In addition, microarray can identify abnormalities not ascertained by conventional cytogenetics. So you can get smaller abnormalities in chromosomes. And so it's really, been transformative. Now, this is becoming old news because there are even newer technologies, whole exome sequencing and whole genome sequencing, and those are starting to be used clinically as well, but they're still not widely available other than on a research basis, and we'll talk a little bit about that. So microarray, for karyotypes, you pretty much can identify with staining, even with high resolution karyotypes, 5 to 10 megabases. So you can get aneuploidy, whole extra chromosomes or whole missing chromosomes, or deletions and duplications. With microarray, you can get coverage at a much higher density, so you can get small additions or small deletions that may involve as few as 50 kilobases. So these are termed copy number variants. Some of those are pathogenic, some of those are really common in normal people, and then some of them are of uncertain significance. So in the SCRN, we did a study using microarray in addition to karyotype. There were 532 stillbirths that had array and karyotype. And the success rate of the array was much, much higher than the karyotype, 88% to 70%. And in current times, the arrays are actually even more successful than that. Abnormalities, aneuploidy and pathogenic copy number variants in the array, for karyotype, it was 5.8%. For the array, it was 8.3%. So we were able to find abnormalities in several percent of cases that were not found just using karyotype. It's noteworthy that the microarray can identify many other kinds of abnormalities that may be tangentially related to fetal stillbirth. And I'll just show a little bit of data. I don't want to get too far into the weeds, but we use the same microarray data, and we found that microarray was associated with having a small baby. So there are certain genes that are relevant to fetal growth, also associated with having a large baby. And so some of those genes are indirectly related to stillbirth. We also found that there were specific genetic abnormalities associated with placental abnormalities. And for example, with the maternal vascular perfusion, 81% of the microarrays had that compared to 64% of normal microarrays. And we also found more microarray abnormalities with when there were birth defects. So this is something that's of great ongoing interest in research. Even more potentially impactful is whole exome sequencing and whole genome sequencing. And so for chromosomes, you can identify whole extra chromosomes or missing chromosomes or thousands of base pairs. For microarray, you can identify additions and deletions of as small as 50 base pairs. But as you all know, there can be genetic abnormalities that are a single base pair mutation, things like cystic fibrosis and sickle cell anemia. And so if you did a microarray on somebody with cystic fibrosis or sickle cell anemia, that would be normal, but they still have a genetic abnormality. So we did a study using whole exome sequencing on the SCRN samples, 246 cases that had no clear cause of stillbirth, including normal karyotype or microarray, and they had DNA where we could do this. And then again, you have to decide whether these mutations or polymorphisms, these changes in your base pair, are pathogenic. And we use criteria that I won't get into for this talk. And in this study, 18% of stillbirths had a genetic cause. And we found a percentage from karyotype with aneuploidy. We found a percentage from microarray, but a whole additional 5% through single gene mutations. Most of these cases had a multi-system developmental disorder. Several genes were relative to cardiac function. They had channelopathies. So you had babies that looked normal, were grown normally. You had a normal placenta, but they had a cardiac arrhythmia. And that appeared to be the cause of stillbirth. There were some that were associated with birth defects, but relatively few. So I think many cases that we think are currently unexplained will end up being genetic. And I think that will really transform the research in this field in terms of providing explanations to some families, and then trying to help them in subsequent pregnancies, whether these abnormalities are de novo and just happened as a mistake after that egg was fertilized with the sperm, or whether it runs in families, in which case we can counsel them differently regarding subsequent pregnancies. Infection is another opportunity for improvement. And it turns out that in the past, we recommend doing a battery of tests to look for infection. But it turns out that those are not helpful in the absence of clinical problems or evidence of problems on autopsy or placental evaluation. And so my recommendation would be to do autopsy and histologic evaluation of the placenta, membranes, and cord. And then if there's a suspicion, the pathologist can obtain cultures and nucleic acid specimens as needed based on the histology. But routine cultures or serology is controversial and is really almost never been helpful in the absence of clinical symptoms or in the absence of something on the autopsy or placental histology, even though traditional recommendations have been to do things like parvovirus serology, syphilis screening, or screening for torch titers. So I wanted to introduce some of the epidemiology and some of the causes of stillbirth and talk about some of the newer things in terms of evaluation of stillbirth. But I'd like to spend the remaining time talking about how we can reduce stillbirth, and especially in high resource settings. And conceptually, in order to think about this, the way I like to approach it is there's kind of two buckets. For us to get better, what we have to do is take the stuff that we know, the knowledge that we have right now, and then actually execute that knowledge and give consistent, optimal care. And then there's stuff we don't know, where if we want to get better, we're going to have to do more research and then make new discoveries and then implement that. And so I think it's worth distinguishing between those two. And I think that's a useful framework for thinking about this problem. So there are some basics, and this gets into doing this stuff that we know. It's hard to do because as docs, we only have so much influence over our society and the logistics of our medical system. But access to quality family planning, access to quality antepartum care, and access to quality intrapartum care would be transformative. There are also modifiable risk factors, and those are hard to modify, as you all know, but they would also favorably influence this. Tobacco, cessation, addressing obesity, decreasing substance use disorder, optimizing comorbidities in patients who get pregnant, who have things like diabetes and hypertension, and rigorous use of single embryo transfer all would reduce stillbirth. What about beyond the basics? In the SCRN data, we tried to ask the question, which cases are most preventable? Now, we used a very, very, very rigorous criteria that were very conservative. So I'm not saying that only 22% of stillbirths are preventable. A much higher percentage are preventable. But using the most conservative criteria, saying if we just did what we already know how to do and what we're supposed to be able to do, which ones would be preventable? And about a quarter fell into that category. And the highest single group of conditions were placental. Maternal medical complications, were an important contributor. Gestational hypertensive disorders, an important contributor. And spontaneous preterm birth, a little bit of intrapartum. But the largest group were placental. And again, this is not, we don't have to discover new things. We just have to do what we already know how to do. So there are many ways to address placental problems. And one is to do more screening once the pregnancy happens. But we're also very interested in, can we build a better placenta? And when we have placental insufficiency, it's often because the placenta doesn't grow and develop normally, or it's because the placenta grows and develops normally, but it becomes damaged either through blood clots or inflammation, and it fails to function. So can we increase placental blood flow, either maternally or fetally or both? Can we improve placental growth and development? Can we prevent placental damage? And can we decrease placental inflammation? And there are certainly some conditions associated with stillbirth that are associated with inflammation and thrombosis, like antiphospholipid syndrome. It turns out that low-dose aspirin is something that can both decrease inflammation and improve blood flow. Heparin and low molecular weight heparins have also been used for this. And then there are several other anti-inflammatory agents that are potentially useful. This is an old slide, and there are some newer data, but the results are exactly the same. So I haven't updated the slide. But aspirin has been used for preeclampsia prevention, low-dose aspirin. Really important to distinguish low-dose aspirin from high-dose aspirin, because high-dose aspirin may have some untoward fetal effects, but low-dose aspirin is relatively safe, although the optimal dose is controversial, and happy to talk about that later. And there have been many, many high-quality trials to assess this. And preeclampsia tended to be the primary outcome, using low-dose aspirin versus placebo to reduce the risk of preeclampsia, but other things were studied as secondary outcomes. And on balance, there's about a 15% reduction in preeclampsia. Probably need to treat about 100 patients to prevent a case of preeclampsia. As secondary outcomes, there's about a 14% reduction in preterm birth, and probably need to treat 72 patients to prevent a case of preterm birth. And fetal neonatal death, a 14% reduction, probably need to treat 250 to prevent that. So pretty high quality data for this. There was a recent trial that I participated in called the aspirin trial. And it was a randomized trial of low-dose aspirin or placebo in low-resource settings. It was done through the Global Health Network of the NICHD. And patients were treated in the first trimester through 37 weeks. There were 12,000 women randomized. And the risk of preterm birth was 0.89. The risk of preterm birth less than 34 weeks was 0.75. And the risk of hypertension less than 34 weeks was 0.38. So these were low-risk, nulliparous women. And perinatal loss, the relative risk was 0.86. So really kind of a very robust finding. And I think there's the potential for aspirin to have favorable impact on stillbirth rates with wider utilization. Unfortunately, for the other things, there's really not high quality data that they're helpful. And in fact, there's really high quality data that a lot of the things that we thought might help placental function don't work. Almost uniformly negative studies for unfractionated heparin, for low molecular heparin, for nitric oxide donors, for selective phosphodiesterase inhibitors, for prednisone. Hydroxychloroquine and biologics haven't been as well studied, so they have potential, but so far they haven't been shown to be efficacious. Now, infection is another opportunity. It's hard to really impact the stillbirth rate by trying to prevent an infection in high-income countries, because there are many organisms, all of which only cause a few stillbirths. But as you all know, and I think Ron Gibbs has given a talk during this conference, that congenital syphilis is making a comeback, and so syphilis screening and treatment can really be impactful, and that there's potential utility for doing more rigorous syphilis screening during pregnancy than we're currently doing. Gonorrhea and chlamydia screening are also valuable. Group B strep screening and treatment may be helpful, but it's somewhat unclear. Antibiotics for ruptured membranes can be helpful. Immunizations for viruses can be helpful, and some of the other public health measures that are taken may be helpful, although in very small numbers of cases. I think there's also a research focus on ascending infection, which contributes to preterm labor, and that pathophysiology that can be helpful. There's a dramatic opportunity for infection prevention to help reduce stillbirth in low and middle income countries, because there's a considerable burden. Syphilis screening and treatment, gonorrhea and chlamydia screening, immunizations for viruses, and malaria prevention and treatment can really be profoundly impactful. HIV prevention and treatment can also be useful, even though HIV itself is not a major cause of stillbirth. When untreated, it can be. And then again, a focus on ascending bacterial infections. I'm not going to focus on this slide because it's getting into the weeds for malaria treatment in low resource settings, but there really is an opportunity to impact hundreds of thousands of stillbirths with more effective screening and treatment for malaria. Another major controversy is fetal movement counting, and everybody who's worked in obstetrics knows that decreased fetal movement is often a first clue that there's something wrong with pregnancy, and is often a first clue that there's a stillbirth. It's also often a clue that there's something wrong with the baby, and when patients will come in with decreased fetal movement, sometimes we'll do an urgent delivery and perhaps save the life of that baby. However, when people have introduced protocols to try to get patients to count fetal movements, to come in, to have a systematic approach to managing these patients, people have not been able to show a benefit. And a recent systematic review and meta-analysis of 5 randomized trials, 500,000 fetuses, decreased fetal movement led to fetal monitoring. There was no difference in the perinatal death rate in the counting group and in the control group. And there was no improvement in secondary outcomes. And there might have even been an increase in harm because there was a slight increase in the risk of preterm birth, induction of labor, and cesarean delivery. The best study that's been done, in my opinion, is something called the AFFIRM trial. It was a step wedge cluster randomized trial. So you would introduce this protocol in a hospital and then introduce it into another hospital and another hospital based on the randomization. And it was conducted in the UK and Ireland. And there was a package that was done if there was decreased fetal movement. And they had 3 time periods: control, a washout, and intervention. And they had a e-learning program for clinicians and for patients. They had a management plan. And the management plan were the kind of things you would expect: non-stress test, ultrasounds, induction of labor. The primary outcome was stillbirth. They had a trend towards a reduction of stillbirth of 0.9, but it was not statistically significant. So it's a negative study, but it may have been underpowered. So what are the next steps? Well, one possibility is to say, look, this is really helpful. You had a trend in the right direction. You simply didn't have enough patients enrolled to study this rare but terrible outcome and do larger trials because you were underpowered. Another approach, which I think is useful, is better risk stratification. The problem with decreased fetal movement is it's so common that it's not specific. And even though decreased fetal movement can be an incredibly valuable clue, most of the time it occurs in completely normal pregnancies. So if we had a way of saying you have decreased fetal movement and your baby's really in trouble versus you have decreased fetal movement and your baby is fine, if we got better at that risk stratification, I think that would be useful. And that could potentially be done with biomarkers and ultrasound. And something that people have suggested, and it's currently being studied, is to assess something called the cerebral-placental ratio. We also may need better interventions. It's also important to acknowledge that decreased fetal movement just may be too nonspecific and too subjective to ever really be useful. So this is a major unresolved controversy and question as to what the best way to utilize this clue to reduce stillbirth. Another potential intervention is delivery. And this is a slide just showing your rate of perinatal mortality by gestational weeks in the United States. And you can see that it's relatively high from 20 to 24 weeks, and then it's relatively low in mid-pregnancy. And then as you start getting towards term, it starts rising. Another way to look at this is perinatal death naters between 37 and 38 weeks and increases steadily thereafter. So every week that you continue, you're going to have stillbirths per 1,000 ongoing pregnancies. And you can see that it's still pretty low at 39 weeks, but it dramatically increases at 40 and 41. So what's the best time for delivery? Because if you're delivered alive, then you can't be stillborn. Now, you can suffer a neonatal death and you can suffer complications of prematurity. So we need to put all those things together. But certainly delivery is a strategy to reduce stillbirth. And the ARRIVE trial conducted by the MFMU and were part of that it was pretty well publicized. Induction in nulliparous women at 39 weeks gestation, low-risk women who in their first pregnancy were randomized to either be induced at 39 weeks or to have expectant management. And a perinatal composite of all bad things was not statistically significant, but showed quite a trend towards reduction in the patients who had induction of labor, 4.3% compared to 5.4%. 0.80, so 20% reduction in major perinatal composite adverse outcomes. But the confidence interval bounded 1, so you couldn't say it was statistically significant, but certainly went in the right direction, and assuredly with a couple more patients would have been significant. There was also a decrease in respiratory support in the patients in induction of labor compared to expectant management. There was also a statistically significant reduction in cesarean delivery and a reduction in hypertensive disorders of pregnancy. In addition, the patients in the induction of labor group had a shorter length of stay. They actually were more pleased with their experience, and they actually reported less overall pain. That doesn't mean that everybody needs to be delivered at 39 weeks, but it means that it is a reasonable option that at least is not going to cause harm. Someone asked a question, well, what if you just delivered to everybody at 39 weeks? What would that do? And so a model using US vital statistics, induction of low-risk women at 39 weeks, and a very conservative estimate was that it was going to prevent 50% of stillbirths from 39 to 40 weeks. And it would prevent 883 stillbirths per year in the United States, and you'd probably have to do 1,600 inductions to prevent 1 stillbirth. So that's more of a theoretical, but it certainly is a tool in the toolbox. A recent systematic review, meta-analysis of 34 trials compared induction of labor to expectant management. These were all greater than 37 weeks gestation, because the earlier you get in pregnancy, the higher the risk of adverse outcomes. The risk of perinatal death was 0.31 in the induction of labor group, with the number needed to treat of 544. For stillbirth, 0.3. So really dramatic reduction. And cesarean, you also had a lower risk of cesarean for induction. So again, these data have really held up. And so induction is an important tool in the toolbox, especially the closer you get to term, where the risk of prematurity is less. There are many accepted indications for androgenic preterm or late-term birth that we've studied, things like diabetes, gestational hypertension, fetal growth restriction. Many are based on weak evidence, and we use a one-size-fits-all or binary algorithm for these cases, but I think there's a tremendous opportunity for individual risk stratification. And so I think we've gotten to a place where we've accepted that it's an option to consider delivery at 39 weeks, but maybe delivery at 38 or 37 weeks is best for certain pregnancies, or at least, with shared decision-making with families, maybe they want to choose to trade a small risk of prematurity for avoiding a risk of stillbirth. Said another way, if you're sitting at 37 weeks and you have a 1 in 3 risk of stillbirth, everybody would agree that we ought to go ahead and deliver that patient, and that risk of prematurity would be acceptable. But if there's a 1 in 3,000 risk of stillbirth, we'd probably cause more harm than good if we delivered those patients at 37 weeks. There are many models that have been used to predict stillbirth using, machine learning, artificial intelligence, but based on the parameters we currently have, there's very poor prediction. Many stillbirths occur in cases with no risk factors, and so we need much better risk stratification, especially at later preterm or near-term gestations, and that's an area of active ongoing research to try to use ultrasound and biomarkers to better risk stratify. I just want to spend a couple minutes talking about stillbirth bundles. And we have many bundles in the United States that are intended to prevent maternal mortality. We have hemorrhage bundles, hypertension bundles, thromboembolism bundles. Well, in a couple of other countries, there are stillbirth bundles, and there's one called the Saving Babies Live Care Bundle in the UK. It involves several domains: reducing smoking and pregnancy, screening for fetal growth restriction, awareness of decreased fetal movement, effective intrapartum fetal monitoring. It's done at 19 national health service sites in England. They've assessed 460,000 births. And their stillbirth rate dropped from 4.2 to 3.4 per thousand, 0.8 relative risk. There was an increase in induction of labor, emergency cesarean, sonograms performed, and growth restriction detected. So I think those data are very, very enticing. The study design is not rigorous, and there's a lot of bias in a before and after study design. But this is a bundle that was adopted in the UK that, at least based on weak evidence, may have helped reduce stillbirth. There is a similar bundle that's ongoing in Australia, and preliminary results are also promising, but those haven't been published yet. I'd like to finish by talking about some ongoing efforts in the United States. And this is kind of a cool thing. There's something called the Stillbirth Working Group of Counsel from NICHD. And what's cool about it is the reason this thing exists is because of parent advocates. And bereaved parents did a lot of advocacy, especially someone named Debbie Haynes, whose daughter Autumn was stillborn. And through this advocacy, they were able to get some legislation that's in Congress that hopefully will be passed this year. And then those legislators were able to then leverage NICHD to address this. So they formed a working group to focus on a variety of problems in the United States with regard to stillbirth. And the four areas that people have been focusing on are vital statistics and fetal death records, perinatal autopsy, risk factors for stillbirth, and disparities. And then the most recent and then the working group put out a document that's available online through the NICHD. And then there's been another iteration of the working groups, and we've divided into three subgroups: one on data collection, one on stillbirth prevention, and one on bereavement and mental health. There's considerable overlap among the groups, but the output will be policy recommendations and research recommendations. There's a document that is in development that should be available probably in June or July. And here's a list of just some of the potential policies and research areas of focus that will come from this. Universal access to quality care, improved data collection, linking the electronic medical record and vital statistics, updating data in vital statistics when available, which has been a major problem with vital statistics and fetal death certificates, and linking maternal and neonatal records, performing perinatal audits, which are currently done for maternal mortality cases, but not done for perinatal mortality cases, potentially implementing a U.S. stillbirth bundle, increasing patient and provider education, having evidence-based guidelines for decreased fetal movement, using more low-dose aspirin, induction of labor, and growth restriction screening, doing a better job of assessing placental function and pathology, improving risk stratification. These are research priorities with biomarkers and sonogram, studying the pros, cons, cost, and harm of induction of labor prior to 39 weeks gestation, focusing on disparities in stillbirth. I didn't talk about that because of time, but there are major disparities in stillbirth just with almost all other health outcomes. The concept of remote fetal monitoring, potentially helping address some of the inequities and disparities, setting up registries, collecting biospecimens, having more widespread genetic testing. Again, decreased fetal movement is a major issue that needs to be tackled with research. And then helping parents with their mental health, with bereavement, and with decision aids. I'd just like to finish by showing a slide of the Stillbirth Collaborative Research Network. That was a long enough time ago in history that I had a full head of hair. And I will be happy to take any questions.
Wonderful. Thank you so much, Dr. Silver. That was so informative and enlightening, and we have many questions to get to. So first, I want to ask, is there any tech that's showing promise for monitoring movement? As we talk about, standardized testing might be costly, has a lot of risks associated with it as far as implementation goes. So is there any technology that you feel like is maybe part of the future?
Yeah, I think though that's a great question, and I think there are some really exciting things that are in the pipeline that are being tested to assess fetal movement and also fetal heart rates remotely. Um, there are problems in the sense that, and this is always a challenge. Uh, some of these things are being marketed aggressively without proof of benefit, and they have the potential to cause harm and also to have expense. And so there's always equipoise between not wanting to delay too long in adopting a technology and denying people the use of something that's really valuable, but also adopting it too early and potentially causing harm. But there are some things that have tremendous potential that are currently being assessed. So absolutely.
On the topic of testing, we have a question. Is the Kleihauer-Becky test not an inexpensive and potentially valuable test to do for stillbirths that don't have an obvious cause?
That's a great question. I think that it would be perfectly fine to just do a Kleihauer-Becky on all patients, given how inexpensive it is. Um, However, I can tell you that it's virtually never, if you have enough bleeding to actually cause a stillbirth, you'll almost always have some other evidence of that. Either you'll see bleeding, you'll see an abruption, or you'll see abnormalities in the placenta. You'll see some evidence of fetal anemia. So, but you're right; it's inexpensive enough that's a perfectly fine recommendation.
Mhm. We've received a couple questions related to pathology. How many pathologists, in your understanding, have experience or expertise with placental pathology specifically?
I should know this, and I can't tell you off the top of my head how many perinatal pathologists there are in the country, but it's literally not more than a couple hundred.
Mm.
And in most states, they're 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 located just in large referral centers, so they're not available in every hospital. I think it's really important to try to increase the quality of perinatal pathology. So one part of the bill, the Sunshine for Autumn Act, is to actually have funding to train more perinatal pathologists and incentivize pathologists to undergo that additional training. Secondly, there are mechanisms to potentially transport stillborn infants to referral hospitals if we can work through the logistics and the payments. And then thirdly, pathologists who are not perinatal pathologists, but who are willing to do so, if they can follow the Amsterdam criteria, then they could then send pictures or slides to the perinatal pathologists in the referral centers. We could really increase the quality of perinatal pathology and make it widely available. So that's a great question and a very important set of logistical approaches.
Mhm. On that note, does the Stillbirth Collaborative Research Network provide, the center specifically provide pathology services to smaller centers around the country?
Well, that network no longer exists. But there is going to be a new network that's going to be developed. But in addition, this is part of the ICHD Working Group of Council. So we're really trying to come up with some protocols that can be adopted throughout the country that will be a combination of those strategies. So if you live in a large city and you're in a smaller hospital, maybe the newborn could be transported to that hospital. But if you live 2 states over, if your pathologist can follow the right protocol and then send pictures to the referring institution, some combination of those kind of things.
Mhm. We have a couple questions specifically about fetal movement and talking to patients about that. How do you suggest talking to patients about fetal movement and monitoring that? Do you feel that decreased fetal movement might be over recommended to give patients and parents a sense of control in something that largely feels is out of their control?
This is an incredibly complicated and controversial issue because a lot of parents uh, who have experienced a stillbirth are angry because their providers didn't talk to them enough about it. And I think providers are worried about talking to patients about it because they don't want to create anxiety, which is very reasonable. I take care of a lot of patients who have had previous stillbirth, and the anxiety level is tremendous. But the parents who've been through this don't want to have their intelligence insulted, and they would rather be anxious than lose their baby. And so there's equipoise there. The problem with fetal movements is that it's so subjective and it's so variable under normal circumstances. So knowing what the best way to educate patients is in terms of counting kicks and doing this is just uncertain. Personally, what I do is try to help people set their own baseline and then really notice perturbations of that baseline. Others feel strongly about one method or another method, and I think it has to be studied. I think it has to be studied, but I can tell you that there's a lot more regret from parents who weren't counseled about it, who lost a baby, than there is regret from parents who unnecessarily came in to get checked out and went home and things were okay.
Mhm. We have also received quite a few questions related to your slides about aspirin. If you have any thoughts about the recommendations for the 81 milligrams versus 160 and the new study that's been put out on the 162 milligrams for those with elevated risk of preeclampsia, if you have any thoughts on that you'd like to share.
You bet. I think we're oversimplifying this, and I think we actually need more studies. Most of the studies have been done with 81 milligrams because that's the only dose of low-dose aspirin in the United States. And a lot of studies in other countries have been done with 100 milligrams or 120 milligrams. There's some evidence that 160 may be better than 80, but that hasn't been uniform in all studies. And then there's incredible individual variation. Number one is your metabolism of aspirin is very much influenced by weight, by your BMI. Number two is there are different genes that are related to how you metabolize aspirin. So the same two patients aren't going to metabolize it in exactly the same way. So we really need more studies to find the best dose. And the only reason we're talking about 162 is because in the United States, it's only manufactured as 81. So I think a key message is don't take 325 because that's too much. And whether it's 81 or 160, I think either one's probably okay. And ideally, we'll be able to individualize it where we can say, you've got this gene and this is your weight and this is your dose. But we're not there yet. So to me, it's much more important that you take it or don't take it rather than we argue with certainty about the dosing when we're really, if we're honest, we're just uncertain about the best dose for each person.
Mm-hmm. Do you think there will ever be a recommendation to start low-dose aspirin earlier than the 12-week recommendation, or are we moving in that direction in some capacity?
I personally have a bias that it can even be done pre-conception. I think there's some value to doing that. And there's certainly no harm, but you know, again, it's not unequivocally proven. And again, you have that equipoise of if you wait for everything to be 100% proven, you'll never do anything, but you also don't want to adopt things too early. The thing about low-dose aspirin that's important to note is that there's incredibly little downside. So most things we don't get to say that about. And so I'm in favor of overutilization rather than underutilization, mainly because there's so little downside.
Mm-hmm. We have another question here. If there have been any studies about the correlation of Ehlers-Danlos syndrome with stillbirth. One of our attendees shared that they experienced this stillbirth with this diagnosis as well, and had a couple following subsequent preterm deliveries, as well as finally a full-term baby with their third. But if there's any correlation with Ehlers-Danlos syndrome and stillbirth.
Not to my knowledge, you know, certainly with vascular Ehlers-Danlos, there can be very serious maternal complications. And with, I'm assuming this is more of a hypermobile type of Ehlers-Danlos. And there is a loose correlation with an increased risk of preterm birth. But for most of those folks, they do pretty well. So you can never say never and always, but it's not been written about to my knowledge.
Mm-hmm. Has there been any research on the prevention of cord accidents resulting in stillbirths?
There has. It hasn't been very good, and it's an area of active research in our group, and I think it's really an important question. And we've been guilty of overascribing stillbirths to cord accidents, because if we see a nuchal cord, people will say, "Oh, it's just a cord," and they won't do an evaluation, of stillbirth. And the problem is that you can have a nuchal cord in up to 30% of pregnancies. You'll often see a double or triple nuchal cord, and the kid comes out screaming and it's perfectly fine. And you all often see true knots in the cord. So we've overascribed stillbirths to cord accidents. We've also made a mistake in the other direction. People in academic centers like me say, well, cords never cause stillbirth because we overascribe it. But there are cases where there's really good, evidence of cord constriction, and there's clear evidence that there was an acute, hypoxic insult to the baby. So there's no question that it is an important cause of cord accidents. The problem is other than intrapartum monitoring, we haven't really been able to figure out how to separate the wheat from the chaff. Because if you do an ultrasound and you see a nuchal cord, and you were to just, deliver all those patients early, you would cause more harm than good, because it's so common in normal pregnancies. And so we have to get better at risk stratification there. And there are some things you can do on ultrasound that are 100% investigational, but we have some really interesting preliminary results, and we're hoping that will lead to a better way to risk stratify those patients. But I think it's a major opportunity to do better.
Absolutely. We have another question. If you could please talk about interpregnancy intervals after term stillbirths.
You bet. So you all know what the recommendations are for interpregnancy intervals, and those recommendations are based on reasonably high quality data. But the increase in the risk of adverse outcomes, if you have a short interpregnancy interval, is really relatively small. And sometimes psychologically, for those parents, getting pregnant sooner is so valuable. And for those parents, waiting is incredibly frustrating. And the only thing that makes them feel better is working towards their goal. So often the benefits of getting pregnant sooner outweigh the risks. In addition, pregnancy loss is a different thing, and it's really kind of a gauche thing to talk about. But if your baby hasn't survived, you're not staying up all night, and you're not breastfeeding, and it's not as hard on your body, and so you recover quicker. So I think the benefits of getting pregnant sooner, if the parents are emotionally inclined to do so, far outweigh the downside of slightly increasing your risk of adverse outcomes. It may be different if spontaneous preterm birth was the pathophysiology involved in the stillbirth. We've actually done a bunch of studies on this in patients with pregnancy loss, and there really was no benefit to delaying pregnancy. So I think that's a really good question.
Yeah, I would love to continue talking about the post event of losing a baby, and if you could talk more about how physicians communicate that to parents and trying to describe the cause, sometimes if it's unknown, or that waiting period that patients will go through waiting for pathology reports or autopsy reports, and what kind of support we have now for patients after a stillbirth.
You bet. So I could talk about this all day, but I think the key thing is we've gotten much better at it, and that there are many, many more resources available. So number one is patients should always be referred for psychological counseling and therapy, bereavement support if they desire. They should always be referred to support groups. I've seen some things come and flying through in the chat, but there are many parent support groups, bereavement support groups, advocacy support groups. as clinicians, we really need to spend time with these folks. And so having them come back in, not at 6 weeks, but much sooner, and checking in with them by phone, by text, by in person, all of those things are incredibly impactful. And then there's been really an explosion of really high quality studies in terms of what kinds of things really facilitate bereavement and emotional healing and reducing the risk of anxiety, depression, and PTSD that are beyond the scope of the 30 seconds that we have. But they're out there, and anybody's welcome to call me, and I'm happy to point you in the right direction.
That's much appreciated, I'm sure, by many of our attendees today. Well, I'm going to call our time because it is now time for our midday break. Thank you again so much, Dr. Silver. This was an amazing conversation and really enjoyed your presentation this morning. Thank you for all of our attendees for listening in.